Go. Okay, this is going to be a hanging arm cast. And the difference between this and a long arm cast is the actual proximal border ends 1 inch to right at the fracture site. How do you know where that is? X-ray can confirm it for you, but most of the time this cast is going to be used for a midshaft humerus fracture. And you will be able to control the angulation of the patient's bone just by how you position the arm in the cast. Now these people are in a lot of pain, so typically what I make them do is lean over, hold the thumb, so that therefore they're going to automatically, they're going to radial deviate for you. I pad very similar to a long arm cast. And again, this I'm trying to get as close to real life as possible, where these people are in a lot of pain and you need to be able to get in there. In real life, the patient will not hold their arm up for you. And a lot of them want to pass out. They're in so much pain. So we're assuming mid-shaft, so we're going to go just slightly above it. This cast must be in plaster. You need the weight. This cast is designed to pull traction. So you have to have the weight of the plaster. Pad the olecranon on. She's a little bit more than 90. We'll relax her. Radial ulnar styloid, get a little extra. And I'm liking that. So far it looks like some people's long arm cast, but remember, I like to pad a little bit higher than my border, so my border will probably be, my cast will end probably right around there. You will need a splint. You can go full thickness splint on this. And the reason for that is, again, you want the weight. This cast will coincide with a collar and cuff, which I'll be able to show you. And you will also be able to see how to position the patient's bow and cuff to help correct angulation in the fracture. I'm not too concerned about her radial deviation, her flexion, or anything like that. I can make minor corrections once I've got this whole thing done. Again, with her leaning forward like this, it really allows gravity to take effect, and therefore they don't have to hold their arm up. They're just relaxing. A quick lamination, double check position. Posterior splints. You need to hold your thumb again. I mean, sometimes if you need more traction or more weight, you can add more plaster if you have to. That's what this cast is for. Your parameters, right below mid-palmar crease to, again, fracture site or 1 inch above fracture site. You like a little bit of dorsiflexion, about 15, 20 degrees of dorsiflexion, slight pronation. space that out because I like the weight of it. Mold. I will hold. I've got it. Maintaining 90 degrees. Now I can get my little bit of dorsiflexion, correct my radial deviation. You see the plaster's changing a different shade. It's actually dulling, meaning I got to stop messing with it or I don't want to break it. Just support underneath there. That's fine. Now I'm going to show you how the collar and cuff works with this. So the collar and cuff functions just like what she's doing right now, how I rolled the cast, allowing gravity to take shape. Now some cuffs or collar and cuffs actually have it to where you have to incorporate it in the cast. This one here is just kind of this to kind of give you a little demonstration of how this whole thing works. And you can let go. And by having this cuff here, you're always pulling traction. If you were to put this person in a sling, you'd actually be supporting and displacing the fracture even more. So allowing this the way that it is, it constantly hangs and brings the fracture apart. Now, I can change the angulation of this bone. If we're dealing with a posterior bow or an anterior bow, you can correct that by where you position this. So if she had an anterior bow here, I would lift this up and see how the edge of the cast digs in. It would actually correct that deformity. In a posterior bow, I would lengthen it, and you could see how it pushes in here and would correct that deformity. Now, varus valgus, which would be apex towards me or apex away from me. You would position that with the loop more dorsal, and that would push this cast into the varus deformity, which is the most common in this type of injury. And then the opposite, I would go more volar with the loop, and it would push the cast more valgus. Okay? So, hanging arm cast.